Good morning, everybody. I would like to present my one-year progress report on my PhD topic, which is screening and prevention of adverse pregnancy outcomes in Hungarian population. I'm a resident doctor at the Gynaecological and Obstetrics clinics, and I'm also a PhD student of the Translational medicine. As a vision, I would like to prevent adverse pregnancy outcomes, such as preeclampsia and preterm birth, to reduce avoidable fetal and maternal complications. As a mission, I would like to develop a reliable screening model for pregnancy complications leading to preterm birth. I have two ongoing projects, and I would like to talk both of them. So the first is a low-dose aspirin. Is about investigating the effects of different doses of low-dose aspirin. And to this, I would like to give a quick background to you. As you might know, the incidence of preeclampsia of all pregnancies is approximately 5%. And it has been already proven that low-dose aspirin can reduce the frequency of preeclampsia. But there is no consensus about the optimal dose of low-dose aspirin. By this study, our aim was to investigate the safety and efficacy of different low-dose aspirins during pregnancy. To answer our clinical question, we examined pregnant patients who were treated by different doses of low-dose aspirin compared to placebo. And as outcomes, we examined preeclampsia, preterm birth, small for gestational age, and other fetal and maternal adverse outcomes. We conducted a systematic search, and by this we found 62 eligible full text for the analysis. As you can see, our outcomes. There are 8 different outcomes, and I would like to highlight the outcomes where we find a significant effect of the aspirin. So in preeclampsia, intrauterine growth restriction, gestational age, and birth rate, and perinatal death, aspirin seemed to be effective. To conclude that in preeclampsia, overall, as you can see that these are the risk ratios for the overall effect, and by the subgroups you can see the milligrams here in the upper line, and the confidence interval and the risk ratio in the middle. So by these we can say that overall that giving aspirin for pregnant patients, the prevention of preeclampsia can be prevented by aspirin usage. By this analysis, we found that 75 and 80 milligrams of aspirin were the most effective and had a significant effect. For intrauterine growth restriction, we also have seen that overall it can be avoided by using aspirin. And in this case, we found that 75 milligrams and 150 milligrams was significantly effective. For gestational age, which is in mean difference, not in risk ratio, we found that overall, by using aspirin, we'll prolong the pregnancy about 2 to 3 days, and we found that 100 milligrams seemed the most effective. For birth rate, we also had significant outcomes, and in these cases also 100 milligrams seemed to be the most significantly effective. I think one of the most important questions is perinatal death, and in this case we also found an overall significant effect, and a significant effect for 81 milligrams of aspirin. Just to turn it back, I would like to show you that the reduction rates by aspirin prophylaxis can be shown that in 1,000 treated cases, 1,000 women treated by aspirin leads 10 fewer cases in proteinuric preeclampsia, 9 in small for gestational age infants, and 5 fewer deaths per 1,000 women who are treated by aspirin. But what this study also shown us that for preeclampsia, aspirin has a dose-response correlation, as you can see by this graph and these lines, that every 25 milligram increase in aspirin dose was associated with a significant 7.2% decrease in the risk of preeclampsia. The strength of this study that this is the first dose-response assessment of low-dose aspirin, and we have a really huge sample size. The limitations that can limit the study, that classical dose-response meta-analysis requires more doses in each article, which we do not fit in, and as I already said, we try to include as many patients as we can, so the population is a bit heterogeneous, and there might be some differences in outcome measurement definitions. But as a conclusion, I would like to say that aspirin helps to prevent preeclampsia in high-risk patients without elevating the fetal and maternal risks, and aspirin administration is crucial to prevent preeclampsia. For clinical implication, with all the benefits, at least 100 milligrams aspirin is indicated in high-risk pregnancies. Our second topic is an observational study, which we would like to start. And just to give a background, preterm delivery the incidence of preterm delivery is nearly 12%. And it is a crucial question to screen patients with potential preterm delivery. And we would like to use a combined screening model by measuring the cervical length and obtaining maternal history. For this question to ask, we will examine pregnant women with singleton pregnancies who are willing to deliver at our clinic. And we will compare shortened cervix on the second trimester screening to normal length cervix on the second trimester ultrasound screening. And as an outcome, we will examine preterm birth. We will include every patient in our clinic, and we will draft to them in 2 groups with normal cervical length and shortened cervical length. And we will examine the incidence of spontaneous preterm birth. So by these 2 topics, I would like to get inside, and I think by finalizing and by writing the article, we would like to submit them in these years. So thank you for your attention, and I would like to close my presentations with the words of Steve Jobs. If you're working on something that you really care about, you don't have to be pushed, the vision pulls you.
Thank you, Balázs, for your results. And remarks, Balázs, you presented some very interesting data. I mean, 75 milligrams were effective, 150 were effective, yes. But the dosages between these 2 were ineffective. Was it due to too less data in those groups, or how is it?
It's a really good question. Thank you for your question. And it might be, it might happen because of a lot of reasons. But in this study, we examined the patients, so the studies we involved were different patient population. Some papers only examined nulliparous women, which also are high risk for preeclampsia, and some papers examined patients with preeclampsia in the obstetric history. So it's really hard to say what is the reason that in some cases the effect of aspirin was effective and was not effective. It really matters on the patient enrollment, I think, in some cases. So the next question would be that who are the patients who benefit the most of aspirin during pregnancy?
Thank you for your presentation, and the question is to your first project. You assess different doses of aspirin, and at 80 and 81 milligrams. This is a very small difference. What is the reason for to include both of them?
Yes, thank you for your question. For this, we had to to answer this, we have to know that in some countries these are in different doses. You can buy the pharmacy aspirin in 80 or in 81 doses. It seems a really little difference, 1 milligram between the two, but for statistical analysis we had to differ them into two pieces.
So this is rather a technical and not a biological or pharmacological reason?
Yes, exactly. Thank you.